Bradshaw. I'm prescribing support dietitian within the medicines optimization team at Oxford CCG. So I'm one of 3 dietitians within the future ICS. There's myself, there's Hannah in Berkshire West and Sarah in Buckinghamshire. So next slide, please. So I'm hoping to look at the role of the PSD dietitian, current dietetic service provision, why do we need PCN dietitians, role of PCN dietitian, how many are there, and what has the response been so far, and a few very quick conclusions. So what I currently do, I look at cost-effective prescribing of oral nutrition products. I produce guidelines and commission policy statements around oral nutrition prescribing. I help with formulary additions around oral nutrition prescribing. I support GP practices through audit, looking at patient queries, and I also act as an interface between primary and secondary care, so helping with any prescribing issues that come up. Okay. So current dietetic services in Oxfordshire, we've got the community dietetic service, which is made up of primary care and home enteral feeding, and we have the acute dietetic services with lots of specialisms, stroke service, eating disorders, mental health, offender health, and myself. Okay. So we've got an ageing population. We know that, and there's an increase in long-term conditions, and this has led to a high demand in primary care. There have been several important health service documents which have defined the challenges facing the NHS and general practice, and these have also proposed solutions. So looking at prevention, improving care quality and outcomes for major conditions, looking at better use of wider primary care workforce to reduce the demand on GP time, and dietitians have also now been added to the R's scheme, which is brilliant. So I think we've already covered first contact practitioners and AHPs working in primary care, so I don't want to go into that. So looking at the role of the PCN dietitian, they can offer first line advice for nutrition and dietetic related conditions, and where necessary refer on to specialist services. For any other conditions, the dietitian will refer straight to the appropriate healthcare professional. The work includes prevention, long-term condition management, and the PCN dietitian can also support with prehabilitation and rehabilitation. So just adding to examples around that. So in prevention, so in diabetes prevention programs, lifestyle interventions to reduce body weight and blood glucose levels, the programs delivered by dietitians gave greater weight loss. So we are quite useful. Also in the management of long-term conditions, so 1 in 12 GP consultations is for GI conditions, and those with undiagnosed IBS visit GPs 10 times more frequently than matched patients. So if the dietitian gets involved, you can see the impact on GP time at reducing contact with this group of patients. If we look at frailty, so following dietetic intervention, patients improved various outcome measures, including their weight, their BMI, and hand grip strength. So if you combine that working with an OT and a physio, you can see it's got to be a positive outcome. There's been reduced hospital admissions, so appropriate and early frail elderly pathway interventions, including dietetic input, can reduce hospital admissions with patients with frailty by 67%. So that's got to be a good thing. So I'll whiz through this one. So this is basically the requirements for a dietitian working in primary care. They basically have to be qualified, registered with the HCPC Council. They're able to operate at an advanced level of practice, and they need access to appropriate clinical supervision, and also a named individual within the practice to provide general advice on a day-to-day basis. Okay. This is a very full slide. All these details are available in the Network Contract Directed Enhanced Service specification, so I'm not going to go through those. And on to the next. So the key wider responsibilities, so undertaking a range of admin tasks, so ensuring that stock levels are maintained, securely stored, and equipment is kept in good working order. So things like ensuring that scales are checked, and that should be done on an annual basis, and ensuring delivery of best practice, so making sure that they're keeping up with their education, doing some research, looking at audit, just so we achieve corporate PCN and local population objectives. Okay, so how many PCN dietitians are there? Well, therein lies a question. It was very difficult to quantify, but numbers are still very low as this is such a new role. So I had a look on NHS jobs. There are currently 9 jobs, and they're from the north through to the south. 5 of them were being offered permanent contracts and 4 fixed-term contracts. 3 of the jobs, they had specialisms specified. So if a practice has a particular population where they need help with diabetes, then that would be specialised. That would be specified within the job spec, and it would attract a different kind of dietitian. So you'd need to fit your dietitian to your requirements. Okay. So this was a straw poll of what PCN dietitians in the southeast are doing. So my colleague Jo, who's on the call as well, she kindly contacted all the southeast dietetic leads for me. So there are at least 12 plus posts that we've identified. 7 have been filled, 5 not yet recruited to. And feedback has been where the PCN dietitian works closely with local dietetics, there has been an increase in referrals to community dietetics who see the complex patients. And the benefit of having PCN dietitians is being recognised. So there had been concern originally that the PCN dietitians would take work away from community services, but it doesn't look like this is the case. Dietetics are able to ask the PCN dietitian to follow patients up rather than GP being expected to do this. So that's got to be a good thing, freeing up GP time, ensuring appropriate follow-up. Seeing a wide range of patients following referral from other practice members. So that's where the bespoke MDT works well. So maybe a physio has picked up that a patient with frailty is also malnourished and is able to refer in. Supervision for the PCN dietitian is lacking. So that's something that needs to be set up in the beginning. And then one PCN dietitian was flat out with patient-facing work with little or no development CPD time to develop the FCP role. So I think that's probably because the role is still so new and we're not sure yet. It's not all mapped out. So conclusions, so working with local dietetic services is key. This ensures appropriate treatment route for patients, so following local pathways, and it's a source of clinical supervision for the PCN dietitian. This is a responsive and reactive way of providing treatment for patients in primary care, so patients are treated sooner and by the right person. The PCN dietitian is able to work alongside other AHPs in the PCN to offer an MDT approach to patient care. And GPs have less pressure on their time, so they can concentrate on other areas. And there's some references